That's great. That's great. Well, it's nice to see everyone, and I do see a couple familiar names, and love to see you. If you are able to turn your camera on, we always love to see a face with a name too. So want to welcome you all to the broadcast this afternoon or this morning. This is our ESAS series, our Essential Substance Abuse Skills webinar. The webinar is worth 1.5 CEUs that you'll be able to make a request to receive following today's event when you receive a follow-up email. So again, I just want to welcome everyone, and I have Dr. Avis Garcia here to talk today about referral, service coordination, and the thing that we know is part of this field, documentation. It's an essential piece, even though some of it seems like it's overwhelming at times. My name is Steve Steiny. I'm one of the managers here at the American Indian Alaska Native Addiction Technology Transfer Center. I'm joining you today live from the University of Iowa campus here at the College of Public Health. I have also on the line from our center, Meg Schneider and Jeff Ledolter, who are colleagues of mine who will be assisting with the webinar today. And of course, our presenter, Avis Garcia. So we're happy to have her with us here today as well. I just have a few introduction slides to go over. I hope this broadcast finds you well. Please sit back for the next hour or so and enjoy the information. We're going to try and keep this with a smaller group. We'll try and keep this interactive if we can. So if you have some questions, please feel free to post those in the chat box. And I know Avis and I were talking before we came on. We may even stop and she may ask if anyone has any clarification questions or comments about today's topic. So let's go ahead and see if we can't get started. I'll go through a few introduction slides and then we'll transition, and Avis will pull up her slides and then we'll go from there, okay? Again, this is the ESAS webinar. Today's topic is referral, service coordination, and documentation. So our event, as most of you know by now, is brought to you by the National American Indian Alaska Native Addiction Technology Transfer Center. As I mentioned, we're located here at the University of Iowa. We are part of a national HTC network, including 10 regional centers, a national Hispanic Latino HTC, and a coordinating office at the University of Missouri. This project is supported and funded by SAMHSA. The content is developed by the presenter and does not necessarily reflect the views or opinions of the American Indian Alaska Native HTC, SAMHSA, or HHS. As most of you know, following today's event, we will send out a follow-up email, which will include links to today's presentation. We'll make the slides available in a PDF format for you. You'll also have an opportunity to request 1.5 continuing education units if that's something you're interested in. And of course, there will be a link to a very short survey. The survey is very important to our center. It allows us to receive feedback from you. It is completely confidential. You can skip any questions you would like, but none of the information that you provide will be linked to you personally in any way. If you have any questions about this survey, please feel free to email myself, Meg, or Jeff here at our center, and we're happy to take any questions regarding the survey. But it's really important that we hear back from you. It helps secure our funding for future presentations such as this. So I want to just thank you in advance for being willing to complete that short survey. I know we are gathered here virtually today, but we wanted to take time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll, and our co-director, Mr. Sean Bear. Thank you. Well, without further ado, I want to turn the floor over to our speaker today, Dr. Avis Garcia. She is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. She is a licensed LPC and addictions therapist and also has her PhD in counselor education and supervision with a specialty in substance use disorder treatment. And work with Native Indigenous populations. Avis has worked in a variety of settings. She is one of our consultants here at our center, but I know that she also is the director for a center there in Montana, which she might share a little bit more about, but really happy to have her here. I consider her a colleague and a friend, and I really enjoy getting to know her over these past couple of years. So I want to turn the floor over to her and just again, welcome everyone to today's broadcast. I'm going to pull this screen down, Avis, and give you a chance to get your slides up. If you change your mind and want me to advance those, I'm happy to do that. But let's give Avis a moment to get the slides up for today. And it's great to see everyone. Thank you.
I'm trying to find how to hit the share screen button on here.
It's that bright green button down there, Avis, right at the bottom. If you can get that, I'm pretty sure I set it so that we can do multiple screen shares or multiple people. Let's see if I make sure. Yep, you should be able to share that.
Okay, here we go. Share screen. Can you see my screen now?
Well, let's see. We're waiting. We're not seeing yet. Oh, here it comes. It's thinking about it.
It's thinking about it. Okay.
Okay, now we've got your desktop, which I love that picture. That looks beautiful. There it is.
Okay.
There, perfect. We got it.
Sorry.
Wonderful. Okay, thank you, Ames.
Thank you. Okay, good morning, everyone. I'm glad that you guys took time out of your busy schedules to attend the webinar this morning. Today I will be talking about referral, service coordination, and documentation. It is the part of the Essential Skills series. And I don't know why I have all of this in there from this before. Okay, here we go. We'll start from here. I will be covering the referral process, service coordination, documentation, community case management from a strengths perspective, and some research information. And Steve had talked about me being a director of a program. I am presently working for the Crow tribe in Crow Agency area in Montana. And so far, I'm really enjoying having relocated from Wyoming. Looking at this next slide here, when we talk about substance abuse treatment, we need to look at having a recovery-oriented response. And As you can see, the treatment response is up and down. There's no smooth line or no from the bottom to the top straight up. It has a lot of ups and downs. So there's remission and then there's severe problems. So they may do well and have a relapse, get back on their feet and go down again. So it's for some people, one time is enough. Some people may need treatment several times. I've been working in this field for 20 years now, so I've seen a lot of different people and different situations with substance abuse, but it's always pleasant experience when you're the counselor to see somebody successfully get their life back on track. When we talk about the referral process, I inserted this diagram here because service coordination is huge. We often don't think about that when we're doing our planning for our clients. And we have to think about everything that could possibly benefit that one individual that is in need of our services. So if you look at this diagram, we start in the very middle, the middle row at the top with the intake, processing, and assessment. Moving on to the treatment plan, looking at pharmacotherapy. Is this a person who's dually diagnosed who needs to be on medication? Oftentimes people have been on medication in the past and stopped for some reason. And a lot of times I've seen them using substance to self-medicate. So that's a common thing I've seen. Then we need to look at the continuing care process. And I remind people that this isn't you come in for X amount of days, for X amount of hours, and you're done. It's a lifelong process that needs to be integrated into one's personal life. The treatment can include behavioral therapy and counseling. So we have a system set up where I'm at to refer to the Indian Health Services Behavioral Health Program, clinical and case management services, substance use monitoring. Some programs do drug testing. We do them randomly at our agency just to ensure that our clients are doing well. And then we have self-help and peer support groups. I have one person who is a peer specialist, and the peer specialist position is new to the substance abuse treatment. I want to say in the last 4 or 5 years, and it's been a great addition to the treatment programming. I have nothing but positive things to say about it. It's a huge help for every program that I've been involved with. So when we're looking at our client, we also need to look at, do they have children? Who's taking care of the kids? Vocational services. So there will be a lot of services that are outside what we have to offer in our agency. The mental health services, medical services. And for those of you that are under Indian Health Services, you know, we're grateful to have the clinic close by. Educational services. A lot of our clients come with limited education. So as part of their treatment plan, I often will include, you know, they're gonna look into taking their GED, or maybe they want to get some job training. We also need to consider AIDS and HIV services. Legal services. A lot of our clients are court ordered to seek treatment, so we need to have that perspective. Financial services. I have to honestly say I've been trying to include more of this into some of our treatment programming, mainly budgeting and getting clients to think about, you know, saving for future things. And housing and transportation services. The Crow Tribe runs a transportation program that brings people in from Billings clear to the Crow Agency every day, Monday through Friday, and takes them back. So that's often a way that some of our clients make it to our program. And then family services. Oftentimes, the Department of Family Services is making referrals to our program as well because they're concerned about some family issues. Next is the recovery-oriented systems of care. This is a comprehensive menu of services and supports combined and adjusted to meet the individual's needs and their chosen pathway to recovery. So again, we have the client in the middle, all those programs I just talked about with you. The systems of care on the outside, these are the addiction services, mental health, primary, vocational, veterans. I forgot to mention that. Department of Defense, health insurance, Indian health, housing, social services, and of course, child and family. And then when we look at the other parts of that's more focused on the treatment, what we're all looking for is reduced crime, safe and drug-free housing, employment, them being abstinent, the use of evidence-based practices, and there are several evidence-based practices, but not all are made for Native American people. So I often refer to best practices, which in Indian country, we can tailor that to whatever our culture practices in a specific area. The cost effectiveness of the treatment programming. We have to evaluate our clients. Is this someone that needs a high level of care, or is this someone who's ideal for our outpatient programming? And what is the perception of care? And of course, we want to look at our retention. We need to do what we can to keep the clients involved in the programming, and access and capacity. So how accessible are these programs to the people that need them? A referral is a process of facilitating the patient's utilization of available support systems and community resources to meet needs identified in the clinical evaluation and or the treatment planning. This is seeking assistance for an issue or circumstance of the client that is beyond the scope of the primary treatment facility. So it's very important to be knowledgeable of all of the community resources that are in your area so that you're able to make the appropriate referrals as needed. You want to establish and maintain relationships with civic groups, agencies, spiritual community, tribal leaders, other professionals, governmental entities, and the community at large. Referral continued. Number 2 is we must continually assess and evaluate referral resources to determine the appropriateness of those resources. We need to make sure that our people show up, did they get what we sent them there for? So you want to establish nurturing collaborative relationships with key contacts in community service organizations and agencies. Like because I work under Indian Health and I refer people often to Indian Health's behavioral health, I meet weekly with the director of behavioral health. Every week we meet for at least an hour, hour and a half to talk about the clients that we send to them. So it's good to keep those communication lines open. Interpreting and using evaluation and feedback data. So you also want to be getting the client's input, give them some sort of form that they can fill out, if not every time they come in, now and then, to see how things are going for them. Giving feedback to the community resources regarding their service delivery, let them know, hey, Jill said she really enjoyed the parenting class, and we'll be sending more people your way. Keeping aware of what's going on in the community. Right now, I'm setting some people up for some Narcan trainings that are going on around here. And I thought, well, why not get the clients involved in that too? That is something that would be helpful. Number 3 is to differentiate between situations in which it is most appropriate for the patient to self-refer to a resource and instances requiring a counselor referral. Interpreting assessment and treatment planning materials, assessing the patient's readiness, being where the patient is, rolling with the resistance versus forcing a change, and educating the patient regarding appropriate referral services. So letting them know why you're going to send them somewhere. And, you know, we can't force them to go either, but it can always be suggested for some resources that they might be able to benefit from that they weren't aware of. Number 4 is arrange referrals to other professionals, agencies, community programs, or other appropriate resources. Explain in clear and specific language the necessity for and process of referral. This helps to ensure patient follow-through. Exchange relevant information with the agency or professional to whom the referral is being made. Evaluate the outcome of the referral. We have now, which has come up lately as a popular part of the referral process, which is the warm handoff of, you know, maybe if we have the time and are able to do so, maybe we bring that outside agency to the client, or we take the client to go meet the person and, you know, give them a warm handoff so they're more open to continuing using the service that we're referring them to. And again, like I said, evaluate the outcome of that referral. How did it go? You know, if it didn't go well, then we're not sending our people there anymore. 8, you want to follow up. It is your responsibility to contact the agency post-referral. Check with the patient, see if they were able to engage in services following the referral. Want to make sure that everything is going well for them. If they need anything else, if that didn't work, do we need to send them to another place? Service coordination. This is a quote from Dennis Banks. Since the beginning, Native people lived a life of being in harmony with all that surrounds us. It is a belief that all humankind are related to each other. We believe we are all related to all other living species, the winged ones, the four-legged, the plant life, and the elements of life, air, fire, water. The sun, moon, stars are there to guide us. So when you look at it, it's like everything out there is a part of our service coordination. Service coordination is the administrative, clinical, and evaluative activities that bring the patient, treatment services, community agencies, and other resources together to focus on issues and needs identified in their treatment plan, which has been developed in collaboration with and guided by the patient. A multidisciplinary addiction treatment team is a group of professionals who have the common task of providing a specific element of treatment to a particular client to address all of the areas relating to the client's substance use disorder. The compositions of the multidisciplinary team varies with the resources and the population being served, and can consist of any combination of professionals, such as the addiction counselor, mental health professional, physicians, psychiatrists, registered nurses, a pharmacy, case coordinators, attorneys, representatives of the criminal justice system, such as probation officers and parole officers, peer recovery support services, and administrative non-treatment staff. Service coordination includes case management and patient advocacy. We are their #1 advocate. And we also need to teach our clients to advocate for themselves as well. A lot of times they've never done that. So it's teaching them a new life skill. Establishes a framework of action for the patient to achieve specified goals, which is the collaboration between the client and all members of their multidisciplinary addiction treatment team to provide the most effective treatment to the client and his or her family. Service coordination involves collaboration with the patient and significant others, family, TOSPE, coordination of treatment and referral services, liaison activities with community resources, ongoing evaluation of treatment progress, and ongoing evaluation of treatment needs.
Avis, we've had a couple of questions come in. I don't know if you would be comfortable maybe addressing a couple of those from the group or.
That would be great. That would be great. I
wasn't
can't see
sure.
them while my screen's on. They're
I
not
know
popping
that,
up.
Jeff, and I thought you probably couldn't see the chat. We've been trying to monitor it, but maybe I know,
Okay.
Chief Michelle had a couple of questions, and then I think it was Catherine Palmer had a question. So you guys feel
Okay.
comfortable, you can ask Dr. Garcia right now a couple of these questions.
Hello, can you hear me?
Yes, I can hear
Yes,
you.
is this,
This is Catherine.
hi, Catherine.
Hi, I just wanted to ask, I know where I'm working, sometimes I bring up, I'm a special education facilitator, and I bring up things about disabilities, and people are saying, we have no information. It's just where it seems like it's in the back closet, and I keep trying to knock on the door and bring out that yes, there are people that have children with disabilities, and these people are family members that have their own issues, and it's intertwined completely. And I was at a meeting not too long ago that I brought up, has this group contacted the local developmental disabilities program? And there were some people that didn't even know about the program through the state or through the county, through the state, and with Medicaid and those kind of things. So I'm just asking what you do know. And then also the part of fetal alcohol syndrome, is that brought up? Because of course, as we know, that is one scenario that can cause developmental disabilities, learning disabilities, all kinds of different things. So I was just wondering if you do discuss fetal alcohol syndrome. Thank you.
That's a really great question. I do know in our actual outpatient groups, we do discuss fetal alcohol syndrome and fetal alcohol effects with our clients because it is a part of our curriculum. So at some point, it's a whole group, you know, they spend the whole hour to whatever amount of time they have having a good in-depth discussion, and you know, we add whatever we can add to that to give them more education on that. As far as the developmental disabilities, I moved from Wyoming, and in Wyoming, we had vocational rehab services throughout the entire state. Also on the Wind River Reservation, we have vocational rehabilitation programs for the 2 tribes that reside on the Wind River Reservation where I come from. So it was almost automatically almost everyone that walks in the door, and not everyone, but several, because with a diagnosis of a substance use disorder, they are considered to have a disability. And that qualifies them for some vocational rehab services. And I do know that they have done a great job with several of our clients that were referred on the Wind River Reservation, as well as in Cheyenne, Wyoming, where I used to run another program. And some of the people get like job training, or they get assistance, like even with supplies. They get a lot of help, but one of their requirements is they stay sober. So we have to have that meeting where we sit down with them and say, you know, these guys are willing to help you with X, Y, and Z, but you need to do A, B, and C. You know, you need to go to your classes, you know, you have to take on that responsibility to help yourself. We, being new to the state, I want to say almost daily, I'm learning the different services that are available in the community. And I want to honestly say I've never really brought up developmental disabilities issues with the client specifically, unless it was an identified problem that we needed to like tailor special needs to meet, you know, treatment service provision for a certain individual. Like you said, I've gotten clients, and I still do, that come in that are illiterate, that can't read. So everything has to be, you know, explained and read to them. A lot of our clients have been struggling with disabilities all of their life, and maybe we need to refer them to an agency to be further assessed and evaluated for whatever disability it is they might have. And working in the substance abuse field, I mean, I run numbers every month on data. I'm a big data person. And I see that the educational attainment levels are often low, and not to be judgmental, but to be more helpful to the clients that we have. You know, some of them do need some extra help with certain things. So it's being able to get to know those clients on a one-on-one basis. But I do, you know, I like how you say you're seeing that, you know, this ain't being done and that ain't being done. So, you know, that's maybe something for you to bring to the forefront in whatever area you are in. But, you know, that gives me something to think about myself too. Being new to the area that I'm in, is I really haven't done a lot of work on the developmental disabilities and other than a lot of work with Medicaid. I don't know if that answered your question completely, or if it helps.
Well, I just want to thank you for visiting about it. It's like I said, I feel I have a son with disabilities. I've been honored to have this position at a tribe, and I am finding that I'm kind of knocking on doors saying, how do you know about learning disabilities and how it intertwines with everything, and communication with family members that are already stressed because they're raising a youth with intellectual or developmental disabilities, which hasn't been tested, so you can't really label, but you can tell with everything going on, you're going, please try, if you're interested in, like you said, testing to see if you're eligible for services. And these parents are stressing out, and where do they turn? So it's a lot of how to support families with the services that are out there and to help them reach those services so they're not stressing out and becoming addicted to something to deal with their pain. Thank you.
Okay. Yeah, thank you. That you made a very good point, that I don't think I've put a lot of emphasis in the work that I do. Other, you know, I am knowledgeable. I have a grandchild who has a developmental disability, and, you know, my daughter is a master social worker herself, so she, you know, knows of all of the resources that are available in where she's living. So it's good that your agency has someone like you who is paying special attention to those people that could benefit from those services.
We had another question
Okay.
from Chief Michelle.
Okay.
Michelle?
Yes, thank you. Just to circle back on what Catherine was talking about with the disabilities and the where do you go, who do you turn to questions. One suggestion that I'd like to make is creating a talking circle just for that subject, to put the feelers out in your community, because there probably are people that have the same issue, that have the same questions, and maybe together create a team think tank to address that issue. But the two questions that I had, one was in the ROSC model, are community health workers recommended along with the peer counselors? And the second question was specifically about number 3. And I think that was differentiate between a situation in which appropriate for patient to self-refer and required counseling referral. I brought up mandatory reporting issues. Just questioning, am I on the right track on that? But the first question was about community health workers. Are they recommended to use along with the peer counselors?
So are you saying, are the peer counselors required to be mandatory reporters?
No. The first question is specifically, do you recommend community health workers being involved along with peer counseling, where the peer counselor is just specific to one thing, but the community health worker can focus more on the global issues and connecting the individual to the resources?
I think that sounds like a really good idea. I am in an area where we don't have any community health workers at the current moment. So I couldn't refer in the area that I'm in, but I know what you're talking about. And I want to say I've never done it. I don't know that anyone is doing it, but I don't see a problem with incorporating that into the treatment program if the individual desires.
And I'm looking at the chat, Steve. What is a CM and behavioral health?
Yeah, I was just like a case manager or a behavioral health aide, so something comparable to a community health worker.
Yeah.
Okay.
Yeah,
And well, the reason I asked that question is I'm a director at Pine Hill Health Network in South Carolina, and it is a community health based system, but it follows the same model, and the community health workers do exactly what you're talking about in this model. They do the case management, they do the intake, they figure out what do you need and where do you need help and what do you want and how can we, and then they link you to these outsources. And a lot of the time these things, we are exactly boots on the ground. A lot of the resources, just like with what Ms. Palmer was saying earlier, is you have an issue that you don't have a solution for, so we create them, we just make them. One that we're about to launch is Indigenous First Steps, which is a program for maternity and pediatric. It's the same model. But the second question was about the mandatory reporting. And again, it was the slide number 3 about differentiating between situations which are appropriate for patient to self-refer and where you're where a required counseling referral is, and I didn't get to finish writing that out. I guess that's required counseling referral is necessary. In that, where is that line when mandatory reporting comes into play?
I'm a little confused here. The mandatory reporting by, are you saying our peer specialists?
Right.
They are given a lot of the same training that our counselors are given. And a lot of the training that my staff receives is CARF driven. So I do know that that mandatory reporting is a part of that. So everybody within my agency knows that they have the mandatory reporting requirement as a helping agency, like the whole agency. So I do have my counselors that do come to me or to their clinical supervisor when they have these issues and how they're going to handle them. So I have one right now that I'm walking someone through, and being new to this area, it's like I'm learning as I go. You know, I'm in a whole new part of the country because I'm listening to you talk about all these wonderful services that you have in your area that we don't have here. You know, every part
I
of the
will
country.
be happy to bring them to
Yeah.
you. So you
Yeah,
can
serving natives
there.
is different. Yeah, is different. You know, we can't just create stuff. You know, we do our best to connect them to everything. But I know my staff encounter things in their work because of there's a lot of trauma, and they know that they have to report. And I having new counselors, and I remember being new to the field myself 20 years ago and being like, oh my God, I found this problem out. What do I do?
Mhm.
And so I was walked through the process with my own supervisors at the time of, you got to do this and this and this and this. Some places should have policy and procedure in place that, you have a ready reference, but I often feel that walking my staff through these, if it's their first time, is real helpful to them, knowing that they're being supported in helping that person when they have to make that report.
And I appreciate that response. I asked that not to put anyone on the spot, but I agree with Steve that mandatory reporting is a separate issue from agency referrals. But I think they overlap sometimes. The reason I ask the question is because I'm asked the question all the time: when is it a mandatory reporting situation? And even though we have a policy procedure for it, we still run into that bear. And for example, we have a close relationship with one of the local law enforcement agencies, and one of the officers spouse has made an outreach to us with certain things that reached the level of abuse. And we were like, okay, if domestic violence, the mental abuse that goes along with domestic violence, we can help you with that. And then it was a midnight phone call. I need to get out. And at some point it was, when does the mandatory reporting come into play? And it's tricky because in this particular situation, we have an MOU with the agency. So it was in that situation, we were about to make the report, but she did herself. Right. Not only agency influence, but human responsibility. That absolutely. Brandy, that good comment there. But we were fortunate in that situation that we didn't have to ring that bell. She did. But that was the reason, and it's very recent. So that was what came into my mind when you were talking about that number 3 with the
Yeah, that's a whole different presentation that I do through the ATTC. I do presentations on domestic violence, and we do talk about.
I'm looking forward to that one.
Yeah, the other stuff that I do is generally not a part of the ESAS, but I get where you bring up the mandatory reporting as part of the service coordination piece.
Thank you.
Mhm.
Thank you all for putting this together. This is a great opportunity.
Okay, thanks.
Thanks, Michelle.
Okay, let's get back to the slides here. I think I covered all of this already. Confirming patient's eligibility for admission, continued readiness for treatment and change. Yeah, not everybody walks in the door and is willing to do things. One thing I am seeing lately is a lot of people walking in on their own. They're walking in on their own now, and I used to think that never happens, but I see it a lot more lately. And complete the necessary procedures for admitting them into treatment. So, you know, we have all that wonderful paperwork that everybody just loves to fill out, but we're required to have it. So implementing the treatment plan is to establish accurate treatment and recovery expectations with the patient and involved significant others. And I've often seen everywhere where most people think they don't need to be involved in that person's treatment. Family might think they're the ones that has the problem, so we're sending them, they need to go get fixed. You know, they don't stop to look at themselves and see that they're in that environment that is contributing to whatever problems that person might be struggling with. So I often tell them, if it's not family, is there a friend? You know, do they have a sponsor? Is there someone that they can get involved as additional support for themselves? So looking at implementing the treatment plan, you want to coordinate all treatment activities and services provided to the patient by the other resources. So you need to be documenting all of it as you progress through treatment with each client. So you want to develop and maintain a community referral list. So most agencies that I've worked in has a list, usually made by the community that, you know, provides human services. So it'll list almost everything that somebody could possibly need. Develop multidisciplinary collaborations within the community, accessible as needed. We have for example, we have a new resource center that opened up in Hardin, Montana, and it's the closest place, you know, next little town close to the Crow agency area. You know, my staff asked, you know, can we go there? I said, yeah, you guys can go there. I said, that's networking and that's collaboration. I mean, if there's services that's going to benefit our clients, by all means, go check it out, you know. Delivering case presentations, using appropriate technology to collect and interpret patient treatment information for diverse services. Service coordination includes consulting, where you summarize the patient's personal and cultural background, the treatment plan, recovery progress, and problems inhibiting progress. Understand terminology, procedures, and roles of other disciplines related to the treatment of substance use disorders. Contribute as part of a multidisciplinary team, and apply confidentiality regulations appropriately. So a lot of the service coordination within my agency takes place in our weekly staffing meetings. So every week, it's like every active client we have gets reviewed on, you know, how are they doing? What's going on? Are they still in the right level of care? Do we need a transition? You know, something came up that new that we didn't know about. So a lot of our clients, I mean, this could go into another topic, come in and don't tell us everything, and we learn things the more we spend time with them. So we need to be mindful of that. Okay. Maintain ongoing contact with the patient and involve significant others, understand and recognize stages of change, other signs of treatment progress, make appropriate changes to the treatment plan to ensure progress toward treatment goals, describe and document treatment process, progress, and outcome. Continuing assessment and treatment planning. You want to use treatment outcome measures. Continuing care, relapse prevention, and discharge planning with the patient and involved. Documentation of service coordination activities throughout the continuum care. So you want to make sure you're documenting everything that you're doing. And apply placement, continued stay, and discharge criteria for each modality on the continuum of care. So right here, when we're looking at the stages of change model, we're looking at where there's pre-contemplation, relapse and recycle. So they've gone from pre-contemplation to contemplating to preparation to taking action and maintenance. So this is where we want to get to the continuing care. You successfully completed your treatment program, so we need to prepare you to continue your process on your own. And then sometimes this happens and we have to go back through the process again. Documentation with so many colors from which to choose. This is a real well-known quote that says, if it isn't documented, it didn't happen. And I learned from a good supervisor of mine that everything I write, just imagine that you could go to court and have to explain it. So I've always kept that in mind, and I share that with everyone because it's really helpful. So some people may get too overly wordy, and you want to keep it simple and to the point. You want to record the screening and intake process, the assessment, the treatment plan, clinical reports, clinical progress notes, and discharge summaries, and any other patient-related data. You want to demonstrate knowledge of accepted principles of patient record management, composing timely, clear, and concise records that comply with regulations. Document information in an objective manner. You want to protect the patient's rights to privacy and confidentiality in the preparation and handling of records, especially in relation to the communication of patient information with third parties. And this is usually covered on the front end when they're first signing up, probably during the assessment process of they're needing someone to have certain types of information. So we have different releases made up for if it's the court system, or is this somebody in your family or your significant other you want to add? Because we tell them, we can't tell anybody nothing. A lot of times I get phone calls and it's a mom or a girlfriend and they want to do all the arranging for this person. And when I realize they're talking about an adult who should be doing this themselves, I just tell them that you need to have this person call and make these arrangements for themselves. And if you are going to be involved, they need to have a release of information. So that I see often. And then, some people say, no, I don't want anybody to know anything. So we don't sign any releases. So you need to apply your federal, state, and agency regulations regarding patient confidentiality. If they're on probation and parole, we have to let them know. We have to communicate, and usually they know that up front. Request, prepare, and complete releases of information when appropriate. 3, you want to prepare accurate and concise screening, intake, and assessment report. You want to get the psychoactive substance use and abuse history. How long have they been using? When did they start using? How often? How much? Physical health, how is their health? I love the ASI because it covers all of this. And the ASI is the Addiction Severity Index. And here in Crow Country, and I know even in Wyoming, we are all using AccuCare that has the addiction severity index built into it, which is nice for the Indian Health Services data collection because they have access to all of that with the push of a button without identifying patient information, and all they see really is the numbers. The psychological information, we want to know, have they had any problems in the past? Have they been treated in the past? Any trauma? If not, and we think there's something going on, this is something that goes into that treatment plan. Social information, history of criminality, what's their legal background, gender identity, and cultural orientation. So, I mean, in today's world, the gender identity is no longer just checking the box if you're male or female. It's all these other identifiers that we have now that we need to be mindful of. It could be a male who identifies as female, so we need to be aware of that. The cultural orientation. When I do my cultural orientation, I look at their cultural orientation as a Native American. There is that range of assimilation into the mainstream. Are you like bicultural? Are you real traditional, or you don't practice any of that at all? So like I said, everybody has their personal preferences and choices, so that, and the reason I like to do that is we make sure we're giving them what it is they want and need out of treatment. And working in Indian country, I try to make as much of everything we do Indigenous based. And anything else that you want to add to that documentation. I think what we're required by CARF is to do a suicide assessment screening. So we have a little short tool that's kind of a simple checkbox that has to be done. So that's always done at our assessment. You want to record treatment and continuing care plans that are consistent with agency standards and comply with applicable administrative rules, including the informed consent, documentation in a timely, clear, and concise manner. You should do your notes on the spot or as soon as you're done seeing that client, and not let them build up and get behind to where you can almost never catch up. I've been there. Recognize the importance of recording treatment and continuing care plans. You also want to record progress of patient in relation to the treatment goals and objectives. So you need to check your patient's treatment plans and see how things are going with them. Use appropriate clinical terminology and explain whenever necessary so that the patient fully understands what you're referring to. Review and update records. There are certain forms that needs to be updated every so many months, depending on how long they're going to be in your program. Prepare clear and legible documents and document any changes in the treatment plan. Prepare accurate and concise discharge summaries, the patient profile and demographics, presenting symptoms, diagnosis, selected interventions, were there any critical incidents, progress toward treatment goals, outcome, their aftercare plan, prognosis, and recommendations. And like I said, I'm new to the agency where I'm working at now, and they just have a simple form that they've been filling out for a discharge summary. And I'm somebody who wants a report that has all of this. You should at least have a paragraph or two on every one of these bullets that's in this slide here. Document treatment outcome using accepted methods and instruments. So you want to gather and record outcome data. What's their attendance like? Are there certain assignments that they had to do? Did they all get done? Did they do a good job? Incorporate outcome measures during the treatment process. So this is important in seeing how well your program is running itself. Recognize that treatment and evaluation should occur simultaneously. So this is an ongoing evaluation of your client. and appreciate the importance of using data to improve clinical practice. Community case management. The last agency I worked at, we did not have any case managers. So my counselors and myself included often were case managers in addition to everything else that we did. At the agency I'm at now, we actually have a case manager. So it's really nice to have someone sitting in the staffing meeting, making all these notes of, things that they need to do to help someone there that needs it. But oftentimes I think it's really good to teach the clients to do some of their own case management and give them some part of that as their treatment plan. We want to use a strengths perspective to case management. I'm someone who likes the strengths perspective to everything in substance abuse, especially when working with Native Americans, not just case management, but your counseling, and my supervision. When I do supervision of my staff, I use the strengths perspective. The strengths perspective seeks to encourage patients to become deeply involved in their own treatment, simultaneously assist patients in learning how to acquire and retain resources that will support their recovery. I like to say, notice the things that they do really well and, emphasize that to them, because it helps them feel better about themselves. And this here is a book that our own Anna Helene Skinstad has co-authored called Counseling Theories and Techniques for Rehabilitation Health Professionals. So this would be a really good book to check out on case management. There are 5 principles whereby the case manager facilitates the patient's identification of his or her own strengths, abilities, and assets. CARF requires, we're kind of governed by CARF. We call it the SNAP. So it's the strengths, needs, abilities, and preferences. So it's just like an acronym that you can easily fill out. So that is important that you document that as a case manager. Assist the patient in focusing goals, identifying alternatives, and locating resources by encouraging the patient to identify his or her own needs. So, just asking them right out, how can we help you? And making note of everything that they say when you ask that question. The strengths perspective to case management serves as a primary advocate for the patient and coordinates all relevant services. Encourages positive and proactive identification of resources in the patient's environment, including community agencies and social supports, which is friends, families, and neighbors, and also works with the patient in the community to maximize the fidelity of the provider's perceptions and the patient's experiences. And case management research. Comparing research results across case management-oriented programs is difficult because of the way the case management concept is defined. More study is needed regarding the degree to which the type of program influences retention. Here is some research site information. SAMHSA is one of my favorites because they often have some free stuff that you can download. They have a lot of manuals called Tips and Taps, their treatment improvement protocols on almost any substance abuse topic you could think of. And they used to send you books, but now you can just download them. And so you don't have to stack up books in your office. You can store them online. There is the National Institute on Drug Abuse, that is NIDA. Prairie Land Addiction Technology Transfer Center, the National Institute on Alcohol Abuse and Alcoholism, the National Office for Addiction Technology Transfer Centers, Iowa Substance Abuse Information Center, the American Counseling Association, the American Psychological Association, the Association for Medical Education and Research in Substance Use, the College on Problems of Drug Dependence, and the National Council on Problem Gambling. One that I didn't see here is NADAC, and that is the professional membership organization for addiction counselors. And if you are a member of that, you have some access to some resources through them as well. Just to summarize everything that we covered here today, we covered the referral process, the service coordination and documentation. So almost every single thing that you do with that client needs to be documented. And I pointed out to my staff, a lot of when you're helping a client is case management, or it's services that we could be documenting billable time to. We covered documentation, the community case management model with a strengths perspective, and just a little discussion on research. Substance abuse is a field that is constantly doing research, and more research is needed. More research is needed for Native American people that is specific to our tribal people, because when you do try to find research that is specific information to natives, there is not a whole lot out there. That's why I'm often saying we need to get more people into school and encourage them to pursue work in the substance abuse field. And not everybody wants to do this work because substance abuse professionals are in short supply and high demand throughout the country. And anything we can do to increase the people that can help is a real benefit. So that summarizes everything. I'll open this back up again for some more questions and a little bit of discussion, being that we have a little bit of time left. I can't see the chat box, so I don't know what's going on in there.
Avis, thank
I
you
can
so
take-
much. Just a lot of great information. I know for some of you, this may be a good review. Many of you may be practicing currently and engaged with patients actively in a variety of behavioral health settings, but hopefully there was some information here that may be added to your knowledge base. We want to open the floor for any questions. So you can feel free to unmute yourself or post something in the chat. We do have a few minutes before we wrap up. I am going to post the link to our survey again, just in the chat here. If you don't have a time to do that today, we'll reach out to you post-event. And yes, my comment about prevention doing a better job, by the way, was just a joke. It was always my running joke with our prevention staff. If you guys would just do a better job, we could shut down our treatment centers. Oh, yes. Well, you have to have a sense of humor working in this field too, right, Avis? That's very
Yes.
important.
Yes.
Yeah. But I do want to just again thank Avis for reviewing this information with us and taking some questions. And again, we have a few minutes, so I want to open the floor if anyone has any questions or comments.
Everybody's quiet.
They're digesting all that information. That's a lot.
The stop share. Yeah, it was a lot of information. I want to thank all of you for taking time to attend today's webinar on this topic. And I hope I was able to provide you with some good information to use in the work that you're doing. And I appreciate all of you that do this work that we do, because it is a big job. And also a part of our being in this profession is being able to get CEUs and ongoing education all the time. So that's why we have this series. And I'm always open to special requests. I do present on other topics, and those are usually done later in the month, because I know someone was talking about mandatory reporting. Again, that falls in a whole different presentation that I've been known to do on domestic violence, family violence. You know, that is something that does come up in the work that we do, sad to say. And a lot of times, you know, some of them are struggling with those issues, and it just takes time for our patients to warm up and feel comfortable enough to tell us what it is they're really struggling with. And every area seems to have a great variety of resources, and some don't. And I'm in an area that is very rural, and a lot of the resources we need are like an hour away. So we sometimes have to troubleshoot how we're going to get this person to that program. And so there's always something that comes up that you're always trying to improve in the work that you do to help the people that need our help the most. So again, thank you guys for being here today. Oh, I hear somebody. See somebody's question here. Let me check it out. To open, okay.
I think Catherine has a question here.
I seen it.
She says, what, I think this is right, Catherine, you can jump in here and maybe explain a little bit. She says, what is your motivation saying for every person that crosses your path? No, I'm not exactly sure what she's asking. Maybe she can unmute.
Well, I'm just asking because I also do a little bit of adjunct instruction online, and I always leave each student with keep going. I'm just asking, what is your saying that you think of to motivate, your motivational little phrase that you have noticed is so meaningful to the people that cross your path and come into your services?
For the people that come into my treatment program seeking services as a client?
Sure, or anyone in the community. What is something that you say that you know really makes a difference for a lot of people?
That is a really good question, because I never really thought about it like that. I often share my personal story in like a minute, and I let the clients, usually in a group setting, especially now that I'm new to this area, and I'm the administrator, so I'm the director, so I'm not always in there. I'm kind of behind the scenes person. Every now and then I have somebody that can't do a group, so I'll jump in and pop in. One of the things that I've shared and openly shared throughout my years of work is what brings me to this field is I grew up in a home where, well, I didn't stay there all the time either. I left. My grandparents raised me because my mother was an alcoholic. And there was a lot of alcoholism in my home and in my family. And I was just telling a new friend that I met recently that, you know, I went through a lot of stuff as a kid, and I know what it's like to grow up in a home. And I was thankful for grandparents that didn't drink and provided a safe home that I could go to, because if it wasn't for them, I would have had no place to go to. And I've met some moms and you know, that are getting treatment for themselves. And I'm like, you know, I always wanted my mom to stop. She never did. Not everybody can, but it's what brings me to the work that I do, is knowing that our Native people need Native providers. They need people like me who are Native, who know what it's all about and how to use Indigenous methods and resources to help our people, which is why we need more. I get people that complete treatment and become a peer specialist, go to college. I have one girl texting me this morning because she's new to the field and she's on my reservation in Wind River. And I'm like, just really honored that she's seeking my help. And she's in an office where there's probably somebody that could help her, you know? And she's like, well, I'm asking you because, you know, this person is, you know, I feel more comfortable asking you, and which is fine. I am here to help everyone and anyone, which is why I'm online. This is the whole why I went back to school and got a PhD, was I wanted to reach more people as an educator. Because now that I'm at the level I'm at, I'm not so more one-on-one, but I always take a couple clients. I always have at least 2 clients that I'm doing individual therapy with, and I'm not, you know, I'm willing to jump in a group, and I share my story and let them know that I chose a different way of life. I don't consider myself as someone in recovery, but I am someone who lives a recovery lifestyle, you know, a wellness lifestyle. And I had someone tell me once, and it was a counselor who said, just because my mother was an alcoholic didn't mean that I didn't have to be one. And I chose a different path. I broke a lot of cycles and stuff. And I let our clients know that come that they can do that too. You can go home and help somebody. What you learn here today, you can go home and share. It might help your family. You know, it might help someone in your home or wherever you go. Share what you learned here today.
May I add just one thing more? I just thought of something. I was talking to a youth. She was 12 at the time, dealing with alcoholism or alcohol issue with mother. And please correct me if I'm inaccurate, but I mentioned to her to separate her love to her mother and the alcohol issue. You love your mother, you hate the
What she's doing.
alcoholism.
Yeah, you love your mom, but you don't like what she's doing.
Thank you.
Mhm. That's all I said.
Again, I just want to thank everyone. Do we have any other, you see anything else, Avis, in the?
Well, I seen on here, somebody hit crisis calls and case management should be considered case management too. And I fully agree.
I don't know who would have said,
very,
I don't know who would have said something like that.
who did that? Steve. You know, we have a crisis phone in our office. We have a crisis line in our office, and sometimes I'm on that phone for hours, you know. Sometimes I'm in my car and the phone goes off and I'm like, hold on, let me pull over. I got to take this call. And I could be on the side of the road for an hour. I'm living in Crow, you know, a lot of times I got to go to Billings for other meetings. And so sometimes at some halfway point I'm on call, I got to answer that phone. I'll be in a meeting and I'll be like, sorry guys, I'm on call. If it rings, I got to step out, you know. And it is a big part of our job. And I do work with my staff, even though I'm the administrator, I do a lot of what they do because I don't want to expect them to do something that I'm not willing to do myself. I want to show them I can do this. I know how. In reading that, I was actually looking at a book on like doing a whole presentation on emergencies, you know. How do we handle crisis? Because I get asked that question often. And I thought, this is something we need to cover.
We do have a small section on crisis management and crisis case management in another ESAS. So if those of you that have been on our other trainings, you might remember we do touch on that. So, or maybe I'm thinking of the alcohol and drug training that we do. I know we have a pretty large section in one of the modules on that. So maybe that's something we could do. We could focus on crisis management because it's a big issue. It's what I used to say is a kind of a drop what you're doing moment. And a lot of walk-ins, you know, in our clinic, we had a walk-in clinic, and oftentimes we'd have walk-in crisis. And that really, whether you're triaging someone who's in detox, or they're in an emotional crisis, it's really drop what you're doing. And that's something that I always emphasize with staff. Now, if your staff is unable to drop what they're doing, and you have multiple crises, that's another issue systemically. So, but yeah, I just thought I would mention that. And again, I want to thank everyone for staying on and joining us today. And Avis and I have talked about, we feel like a lot of folks are getting pulled back into their face-to-face clinical duties. And so we're seeing kind of a drop off in some of our virtual events. So we appreciate your patronage and your attendance at these, because your input and feedback are what makes this happen. So thank you very much.
Mhm.
I really appreciate that this is a continuing effort to keep this virtual. Here in South Carolina, they just announced yesterday 35,000 new cases of COVID. So we're back into this. What do we do? So crisis management issue, I would love to have a training just on that, because just like yesterday, once that announcement was made, 35,000, that's 8,750 a day for 4 days, over 4 days. So everybody flipped out. And my thing with it is nobody's allowed to flip out until I flip out. That's how we handle crisis management at my office. And I was almost there yesterday. But yeah, I would love to see this continue on, even beyond whatever grant funding is funding this. I'd love to see this continue. Thank you for doing it.
Thank you.
Thank you,
Thanks.
Michelle. And I put in the chat too, we'd love to have anyone on here if you'd like to join us for our virtual Native Talking Circle. It's the second Monday of every month. Fred Littlebald Eagle facilitates this, and it's a wonderful hour and a half to be together and be in the here and now and share and let our spirits connect to one another. So join us if you can. If you're not on our listserv, I'm happy to post the link to that registration. We'd love to have you. It's a great group. Thank you. Well, if we don't have any other questions or comments, I think we'll conclude today's broadcast. I was going to try and put the link to that talking circle. If you don't have access to our listserv, I'm just going to put the registration link here. Anyone is welcome to join, and you're not obligated to share, or you can just observe and be part of the moment. But it's really a great event we've had running for almost 2 years now. So I'm prompted by Michelle's comment about we need to continue to provide virtual connection, because we may be in for another bumpy road here this winter. So until next time, everyone, please stay safe and stay connected and stay healthy. And I want to thank Avis for joining us again. It's great working with you, Avis, and it's great to see everyone. So take care. We'll see you again. Tokcha.